So I always get stuck with the presentation right after lunch. So if you nod off, I'm just going to start yelling or doing something crazy, but I understand that everyone's probably a little tired. Just as a show of hands, who either has or is involved in a hybrid effectiveness implementation study of some sort? Okay, great. How many of those are type 1s? Okay, type 2s? Fewer? Type 3s? Okay, a couple. All right. So we got some familiarity with hybrids. Okay, so one of the things that's really different, I guess, or at least important about this particular talk is I'm going to give a pretty good update on kind of current hybrid study thinking from a paper that we published in 2022. It was late 2022, so it's only been out for about a year and a half. So let me just jump into the presentation. So big shout out to Jeff Kern and Sarah Landis, as well as Dennis Lee, who is not listed here. The three of us, or four of us, I guess, total, have done multiple workshops, presentations on this topic, and so some of the slides were co-created or have been shared by these other presenters. Come on. Okay, so just to situate in the traditional translational research pipeline where effectiveness or hybrid effectiveness implementation studies fit, they are pretty much at this place after we start to go into effectiveness study testing and start to think about implementation research, or kind of more further into implementation research in type 3s, but we're still interested in effectiveness. So it's really in this big giant square here where we're starting to think about actually combining some of the research questions and methods of effectiveness studies, which are really asking, does this program work when we move it outside of a laboratory, put it in the hands of more typical clinicians or service delivery systems? And then we also can start to incorporate questions around how do we make this work in those systems, okay? So why hybrid studies? So we're probably all frustrated with the pace of research in general, but in terms of trying to really close the gap, in the research to practice gap that we're all trying to figure out, one thing that we can do is also try to increase the pace of our own research by answering effectiveness and implementation questions in a single study rather than having sequential studies. One that answers an effectiveness question, we didn't learn anything about implementation, let's go try to figure out implementation, and then we'll keep moving. That gets you through multiple grant cycles, looks nice on your CV, but really doesn't push the envelope in trying to close this research to practice gap. So effectiveness effectiveness implementation hybrid studies can really help us to actually move things more quickly through the research pipeline. One of the really important tenets too of hybrid studies is you don't want to wait for perfect effectiveness data before you start to ask and try to understand implementation research questions. So this was actually I'm going to date myself right now. About 25 years ago when I was in graduate school in psychology, there was a movement toward, sort of the evidence-based practice movement was really in full swing. Back at that time, we called them like validated treatments, it wasn't even evidence-based, it was like evidence supported, it was like these very strong terms, and you had to be like on a list, right? You had to like have multiple highly controlled, rigorous, randomized controlled trials, typically with like replication by an independent team. And then you got this like gold star that said sort of like, okay, now we can actually start thinking about implementation. Can some people think of some problems with that type of model besides the fact that it's very slow? We've already talked about. Any thoughts? Steve? Yes. So you end up with studies themselves and potentially interventions that are not particularly generalizable. You also end up with a situation where you've created something that does not have a home because you did not do the research in the context of an actual implementation setting. And then, so there was a lot of research, for a couple of decades really focused on adaptation, right? We were like, oh, we just created these great things. We know they work, but they don't actually work in a place where people can get them. So a little bit problematic. So that actually did slow the pace of research as well, was this like, again, sequential, trying to wait for perfect data. Then we're going to try to understand implementation. Why can't we make this a little faster? So another thing we can think about too with hybrid studies is you have a similar kind of, or a kind of opposite side of the same coin, which is we can start to study, or at least to show data and help backfill effectiveness data as we are doing implementation. This can happen for a number of reasons. One can be just pure clinical inertia. So there is no evidence-based thing for a particular issue. As soon as we have evidence that it's safe and effective, let's start to implement it, and we'll study implementation and gather additional effectiveness data. This is what happened during the COVID-19 pandemic with almost every treatment and prevention strategy, is that as soon as they figured that out, they moved into the real world and they kept collecting effectiveness data to make sure that it continued to work and worked for everyone. But they were also implementing and figuring out how do we implement at the same time, okay? So we can often make the case in all of our areas of research that actually this backfilling of effectiveness data can be a really good approach. So the other thing that we can often think about too with hybrid studies is the relationship between effectiveness outcomes and implementation processes and implementation outcomes. So one that probably anybody who's done intervention research is familiar with is this whole relationship between fidelity of delivery and the effect that you actually are able to generate. Idea typically, and this is usually borne out in real data, is that if you deliver with higher fidelity, the intervention's got a slightly better effect size than if it's lower fidelity, okay? So there's usually a pretty good linear relationship. How do we actually know that this exists if we don't get data from both sides? And both sides in this case is really studying effectiveness and implementation simultaneously in the same study. So one of the things to help in figuring out what kind of hybrid study to do, and also to generate just hybrid research questions, is to start with outcomes. So focusing on where you're going is the first step to getting there. So if you know what you're trying to achieve, we can kind of step backwards into which type of hybrid study you should do. So here's 5 things about this whole issue of starting with outcomes that can be really helpful. So it really helps us to identify the knowledge gaps for the intervention of interest. So a lot of the work that I do is with guideline implementation. It's with very well-established evidence-based care, typically in primary care. And often the problem is not that, hey, there's a new thing, we need to like spread the word and get people to do this thing. It's that evidence-based solutions already exist and no one's doing them, okay? So it's an issue of basically, can we get adoption? Can we get delivery with fidelity? And how do people sustain these things? It's not really an issue of like, hey, can we just get people to do this and like learn about this new thing? It really is, it's already there and they're just not doing it. In some situations, they're doing it, but it's with very low fidelity. So we may have an interest in trying to focus explicitly on trying to improve fidelity of something that's already in practice, but it's not generating the effects that it can because of that low fidelity. Hybrid studies too, when you're starting to think about these different outcomes, we're thinking typically about effectiveness outcomes at patient level, and we're thinking about systems and implementer levels. And so this does help researchers think about those multiple level issues, that we are always encountering in implementation research, and to put a formal kind of framework or paradigm around it. It also can help you, if you're new to D&I, not get stuck in pre-implementation and formative research. I'm really sick of posters, and papers that are purely on barriers and facilitators, okay? It's not particularly informative. It's necessary. It's not that it's not necessary. You have to understand the context of your implementation and what's going to get in the way or what is getting in the way of adoption, delivery with fidelity, et cetera. But if you just keep doing understanding context, barriers, facilitators, and never actually get to action, you're actually not actually doing implementation research really, because implementation research is defined as the study of strategies, right? If we're not even get to strategies, it's all just this formative work, okay? Comment, question?
Yeah, if I'm not interrupting.
No, not at all.
I couldn't agree more with you, and I'm delighted to hear you say that. A lot of reviewers of our R34s and our R21s and our R01 developmental treatment development work increasingly want to see implementation science components in A1 or A3.
Yep.
So it's hard to stand back from that.
Yeah, I think there's a move to expecting that you've done a lot of this work before you even submit your grant, which is sometimes problematic because you need funding to do this, especially to do it well. But particularly for R01s, if your aim 1 is to like try to understand your context, you're probably not going to be reviewed very well because everything that follows after that really should have logistically and logically followed your understanding of the context and the implementation gaps and challenges. So you're either seeing people get pilot studies to do that kind of work, potentially R21s if it's sort of a novel area, but you're getting an R21 to study like determinants of PrEP implementation in primary care. No chance. Like there's so much literature on that, it's never going to happen again, but you still have to get that data for your local context to show preliminary data to demonstrate that your strategies are likely to overcome those barriers and you can achieve the outcomes you want. So yeah, it's a really kind of double-edged sword issue. Like you still have to do this work. There's ways to do it really well that do cost money. So still a place for it, but yeah, it's getting harder to actually have this as like a standalone brand question or aim, like you mentioned. Okay, so doing hybrid studies and thinking about your outcome first can really help you select the appropriate study design. I will keep hammering this home, and I will also probably misspeak at least once and call them hybrid designs, but they're not. They're hybrid studies now, and I'll give a rationale for why we call them hybrid studies instead of hybrid designs or hybrid trials a little bit later in the talk. But essentially, if you know that I have an adoption issue, right, that's my main implementation outcome, I know I'm going to be picking strategies that are aimed at adoption, right? And I'm also going to be selecting sites, practitioners, the number of sites, et cetera, to power on that outcome. Hybrid studies, when you're working with your community partners and trying to pick the implementation outcomes and effectiveness outcomes, is a really good discussion to have with your partners, okay? Because the thing that you see in the literature as like, oh, there's a problem with adoption of these things, may not be the actual implementation challenge or problem that is in the settings you're going to work with. And it also may not be the thing that your partners are as interested in. So there's always a little bit of a balance, but really talking about what do you want to achieve and what is the literature kind of pointing us towards can be a very productive conversation. So Megan Lane Fall and Renad Batis and some other folks published a paper in 2019 that's kind of helpful as well to think about hybrids. They called this, I think it was the subway. Somebody's probably more familiar with this paper than I am. So they actually started this with a focus on the thing. So the evidence-based intervention, okay? So what is it that you still need to know about the thing? Do you need to know whether it works, okay? Do you need to know if this thing can actually work? That's an efficacy question. So that's gonna put you on the red line of the subway. And you're not going to be doing implementation research. You're not going to be doing a hybrid study. You're going to be demonstrating that this thing actually changes the health outcome that you're interested in. Okay, so has it shown efficacy? And you can move into effectiveness. You can go down the yellow line, and we run into the yellow-green nexus there. So has the intervention shown effectiveness? If no, you need to do an effectiveness study. It could potentially be a hybrid type 1, okay? And I think I can speak for Jeff on this because I've heard him say it many times. He and I both feel very similarly that we should not have effectiveness research that's not a hybrid type 1. Like it just doesn't make a lot of sense anymore to kind of, again, if you're going to do an effectiveness study, if you're going to engage with clinicians in the real world, why would you not study at least implementation processes? Why would you not at least try to understand the barriers they encountered, okay? But still, in the pipeline here, or the subway, there still is a place for pure effectiveness research, okay? If there is effectiveness, but it's not great, so it's partial, you can potentially do this backfilling of effectiveness data as you study and trial implementation strategies. So that puts you very squarely in the hybrid effectiveness implementation studies part of the green line. Okay, so let's say it's a very well-established multiple effectiveness studies. Then we can really start to go down this bottom path here of doing mixed method studies, understand context, followed by designing of implementation strategies, followed by test of an implementation strategy. If that sounds like aim 1, 2, and 3 of a grant proposal, you got it. That is such a common typical structure of I'm going to understand context, I'm going to work with my partners to design. I'm actually doing grant reviews right now, and this is the last one I read was exactly this. And then they're going to do a trial. So, I mean, that's fine. You don't have to reinvent the wheel. If it works, it works. But this really kind of shows you where the issue is. I would also argue too that bottom path of the green, which kind of looks like pure implementation research, those studies don't happen very often either. It's very rare that you'd have an implementation study that does not also collect effectiveness data. So that's where we're looking at a hybrid type 3 study. There are some that the clinical outcome is so difficult or costly to get that you can make a case that you can stop at the implementation outcome as part of a causal path, as sort of an endpoint evaluation. But most of the time, we can still get some data to show whether or not this thing was effective, okay? Nope. So this whole question about helping researchers new to D&I think at levels, this is actually borrowed from a paper that I published in 2020, but Hendrix Brown was the inspiration for this slide, which is really showing the difference in what you should be focusing on in sort of effectiveness research versus implementation research. And it's intentionally hyperbolic, okay? So the left-hand side, we are focused almost exclusively on intervention effectiveness. And the dirty little secret of every effectiveness study is that there is implementation strategies being used to support delivery and adoption with fidelity. We might actually do those as part of the research team. We institute trainings, we monitor fidelity, we give feedback about fidelity of delivery, but there's also other things happening in the system that they had to do to accommodate your delivery of your intervention in their system. So it's all happening, we just often don't focus on it. On the other side of things, but again, hyperbole here, in an implementation study, we are most squarely focused on the system itself, understanding those contextual factors, understanding the strategies that are being used, and the evidence-based intervention essentially fades into the background, okay? It's not that it's not important, it's not that we're ignoring it, but it's just not the focus of typically like type 2 and type 3 hybrid studies and just generally implementation research. So a lot of times this really requires a bit of a paradigm shift to really think less about the importance of the intervention and more about the system itself that helps support it. This can also help researchers new to D&I, again, so the whole thing about thinking about levels of systems, when you get into the IRLM, there's a whole talk on IRLM on Thursday, I think, I can't remember, but it's in your agenda. I'll be doing that talk as well. A lot of times we are often, we are going to be focused on the health and patient outcomes. We want to show that we were able to reduce new HIV infections. We want to know that we had reduction of chronic disease burden, whatever it is. But this direct path that we often focus on in effectiveness research, this is grayed out intentionally. This is the intervention has effects on clinical patient outcomes, but implementation research focuses on all the rest of that stuff that helps you actually get to those outcomes and have those outcomes on a scale that's capable of having a public health impact. Okay, so that's why we actually go through strategies, strategy mechanisms, implementation outcomes before we really get to the effectiveness outcome that we're interested in. So a pure effectiveness study would sort of not pay much attention to the rest of this. Said that part. Okay. Yeah, okay. I'm going to go into a whole bunch of this later, so I'm just going to kind of skip through. These are more lengthy slides than are necessary. Okay. So the whole issue about selecting appropriate study design too. So in pre-implementation research, this was a paper that we published in AIDS and Behavior in 2020 that was a mapping review of funded HIV research. And one of our coding things was basically this whole continuum, okay? So a lot of times in pre-implementation or implementation preparation work, which is really kind of prior to either piloting or testing an actual implementation strategy, what we're interested in is understanding context, understanding how to select implementation strategies, how to adapt an intervention, how to adapt a strategy for a particular context, but you haven't actually tested anything yet, right? This is all in preparation for those tests. When you start moving further up the continuum, we often start with a pilot test, make sure it's feasible, make sure it's likely to be effective, has some acceptability. We can then go into testing the effectiveness of an implementation strategy, which is really what an implementation trial is. There's also a class of comparative implementation, which is essentially testing multiple strategies against one another, which you can do with factorial designs. You can do it with, parallel cluster randomized, where you get half the sites go to one strategy, half the sites go to another. And then we start getting into the later stages of how do we actually take to scale the evidence-based intervention and the implementation strategy that has shown to be effective in one of these prior steps. And then, of course, I think in all of these cases, but ultimately we're talking about kind of high level sustainability and sustainment of these things once we go to scale, obviously is the ultimate goal. but sustainability should actually be considered throughout the entirety of the pilot testing process. So some research aims by hybrid study type. So in a hybrid type 1, your primary aim is still determining the effectiveness of the intervention. Okay, that's in that situation of we don't yet have enough effectiveness data, or maybe we're moving to a new system, we're moving to a new population. We've done some significant adaptations to an intervention and want to make sure that our effectiveness data is still strong. So a hybrid type 1 would be indicated there. In a hybrid type 1, your effectiveness aim, or sorry, your implementation aim that's always going to be secondary is really better understanding context for implementation. And I think too, we're moving more into understanding the strategies that were used, the feasibility and sustainability of those strategies for future work, like outside the context of this effectiveness study. In a hybrid type 3, I'm going to skip over to the other side. We kind of flip the script. Our primary aim is determining the impact of implementation strategies, what kind of effect do they have on implementation outcomes, and their relationship potentially with effectiveness outcomes. As a secondary aim, we're going to assess clinical outcomes associated with implementation. I have seen more and more hybrid type 3 grant applications and funded projects recently that the effectiveness aim there is actually aim 3 or aim 4. And your first couple of aims are actually more specific implementation questions or implementation aims. So even though it's a secondary aim, it's not necessarily aim 2. It just always is not, it's just not aim 1. That's definitely not aim 1. In hybrid type 2 studies, which these are the least frequent, at least in the published literature, you have co-primary aims. I'll get to the asterisk in a second, but you have co-primary aims. It doesn't really matter which one you lead with. I would say this is actually more a matter of like grantsmanship and responding to the RFA or the FOA that you're responding to. If it's more of an effectiveness FOA, you may want to lead with determining the effectiveness of the intervention, and then have your co-primary be aim 2 to determine feasibility and impact of implementation strategy, or actually formally testing an implementation strategy in like a dual randomized or embedded trial design. If you were going to the D&I FOA and proposing proposing a hybrid type 2, you may lead with the implementation aim and have effectiveness as the second aim. Okay, it's just a recognition that these have essentially equal weight within our project. You can obviously have one of these be secondary, depending on a couple of considerations. One, again, would be, are you being responsive with the RFA? Do they want more of a test of an implementation strategy? The other thing could be, I hate to say this, but like power considerations. So hybrid type 2s are very difficult to appropriately power on both your effectiveness outcome and your implementation outcome. And so you often have to make a choice based on usually the research question and the RFA that you're responding to, which one's going to be first. And if you're not powered for the second one, you might want to call it secondary aim. Okay. But the premise still holds. They're co-primary, they're given equal weight. I'm equally interested in both the effectiveness question and the implementation question in type 2. Okay, so why should we consider hybrids? Speed is an issue. The sequential examination can be really slow. We don't want to wait for perfect effectiveness data. We can backfill. We've already talked about those things. And the whole issue of relating like levels of adoption and fidelity to the actual implementation outcomes and effectiveness data. We have to have data from both sides of this equation to understand those things. So going back in time, 12 years now, the original paper in 2012 tried to bring some attention to these issues around combining research questions in this way. I wanted to provide a little bit of direction to researchers, examples and recommendations. It was a very clinical orientation, which is why they were called effectiveness implementation hybrid trials. They were both trials and focused on healthcare or clinical delivery systems. Okay, the original paper has been used in a lot of different research designs. It has been used in things that are not clinical at all, even though that was the original, kind of paper's framing. And it really kind of moved to an emphasis on really just the combining of research questions. You don't have to have a trial per se to do a hybrid study, because trial is actually indicative of research design, which we'll talk about. And so 2022, we had the revised typology. I'm going to go through very briefly It's sort of the basic original conceptualization. This is actually mostly included for you guys to have access to, not so much for me to go over. But here's just some like little things to think about with the hybrid type 1s. So again, this is testing intervention, gathering information on implementation. Often these are person level or individual level randomized controlled trials to test the intervention, which is kind of your classic design here. And then your primary outcome is going to be intervention effectiveness. A lot of times we see these sort of effectiveness trial plus situations where then we have something related to the implementability of the intervention, understanding barriers and facilitators. These are often mixed methods process evaluations. There's not an explicit evaluation of the real world implementation strategies. That's just not the point here. We're still doing this under effectiveness sort of design, auspices. And so you're probably going to be introducing implementation strategies to make sure your delivery is effective, et cetera. You're going to use this data to prepare for development of future implementation approaches. Okay, so this is not the definitive, it's not the end all be all, but you're gathering data to make a better case for what direction of implementation strategy you're going to go in. What have I not said already? Oh, one question that often arises out of hybrid type 1s is, now that you know more about the context of implementation and what kind of strategies are actually feasible in the setting you're working in, how might the intervention actually need to be adapted going forward? Like, what problems did you run into that were not easily solvable by the strategies that are already in use that can start pointing you to strategies you need to use in your next study? And then really kind of the bigger question of what's really needed to support people in places doing the thing? Like, what capacity, what levels of implementation strategies? Do we need leadership-based strategies? Do we need ones that are focused entirely on clinicians, ones that are focused on clinical teams? Like, what's the nature of being able to support the thing in the real world? So again, some of the indications are that effectiveness evidence is limited. So an intensive focus on implementation might be viewed as premature, but effectiveness study conditions can offer an ideal opportunity to explore those implementation issues and plan strategies for your next stage. This is sort of if you were going to write, like, why am I proposing a hybrid type 1? This is sort of your narrative for that in a grant proposal. I already said this part that all effectiveness trials do use implementation strategies. We just usually don't call them that, and we don't look at them and evaluate them as such. Part of the reason is too, we're often employing very resource intensive ones. We may be paying clinics to do delivery. We may be paying the interventionists themselves for how many patients they deliver it to. We may actually pay for the care. We conduct frequent fidelity checks. We intervene when things go south because we're focused on effectiveness. And we know if our fidelity goes south, we're in trouble. Yeah, let's skip that. So again, the original definition emphasized secondary aims and questions as exploratory data collection. We did a review a few years ago that has not been published, but we learned a lot. This is the most common type of type 1, right? People are just sort of layering on a little bit of an examination. Some type 1s are actually doing much more intensive focus on implementability, as well as developing and adapting the intervention before an effectiveness trial, which is in and of itself an application of an implementation strategy. And so this often involves either redesigning for dissemination implementation as the first step, or actually doing sort of a designing for dissemination, as you're moving through this process. So one question that always comes up with type 1s is, what if you have a small number of sites? It's pretty common in effectiveness studies to have a small number of sites because you want to have a lot of control. One thing you can do is to expand data collection to naive sites. So clinics that are not yet doing the thing, to better understand their implementation context. I think the first time I ever heard this term was from Renad Betis, which was they sometimes call this engagement without implementation. So these naive sites are not actually implementing the thing you're interested in, but they are contributing expertise, they're contributing data, they're helping us understand the generalizability of the barriers that are encountered in the sites we're working with to make sure that whatever we come out of that study with as a plan for moving forward and going to scale is generalizable. I left these in here. You can read that. This is the intervention is called SMART. It's for HIV prevention that goes directly to consumers. I just wanted to show actually what the funded aims were from this grant. So aim 1 was to adapt HIV EBIs for adolescents, which became the SMART trial or became the SMART intervention. So the adaptation can often be like your first thing if you're trying to move out of a particular thing into a new setting or into implementation. The aim 2, which was actually the primary aim when we're talking about the aim of the trial or the outcome of the trial, was to determine the effectiveness of SMART using a direct-to-consumer delivery model. So that's our implementation strategy, was direct-to-consumer. Aim 3 was our implementation aim, which was plan for eventual implementation of SMART by deliverers in the health system. This study was funded, I think, if I remember correctly, 2016, 17. But again, this is still the type of aims that you would see for a type 1 hybrid. So again, I'm going to flip all the way over to hybrid type 3s to kind of show what that looks like. These are often cluster randomized controlled trials that test the implementation strategy. This would be considered kind of a classic approach to a type 3. Implementation, of course, your primary outcome. Intervention outcomes are secondary. A lot of rollout designs and stepped wedges are pretty common. If anyone wants to talk about those things and pros and cons, happy to. But there are some challenges to doing stepped wedges. They sound great, not always as great as they sound. Depending on the type of intervention, the effectiveness outcomes can be challenging to gather. So one thing that's kind of common for hybrid type 3s is that you're not going to be gathering the gold standard clinical health outcome. So think about if we were going to do a test of treatment as prevention for HIV. And of course, the gold standard is going to be to actually take blood samples and look at CD4 counts. Okay, we're not doing that in a hybrid type 3 when we are rolling out to 27 countries in Africa simultaneously. Just not possible because we are going to be having thousands of people. And so an outcome that we might use then is surveillance-based data for county or country level new prevalence that we can compare to our control sites, to historical data, et cetera. It's a good enough signal to know that, hey, we're actually having an effect or we're not, but it's not the gold standard. It's not the outcome that's going to get your study published in JAMA. Sorry to say, but that's okay. Cost outcomes are increasingly being included in hybrid type 3s. It's pretty rare, I think, to not have a consideration of cost or cost effectiveness, or at least budget impact analysis, which is basically what did it cost to implement, regardless of if it was effective, like just what did the sites have to pay? Those are almost ubiquitous these days. Mechanisms of the strategies, that's an emerging area. There are several RFAs that are now requiring them. I know I've submitted a couple to NIMH in the last couple of years that they wanted some test of strategy mechanisms if you were going to test strategies. Like there had to be something. You didn't have to do like a full mediation analysis, but you had to at least look at the A path or the B path. So hybrid type 3s, we've already talked about most of these. Some of the indications from 2012 is that we sometimes proceed with implementation without completing full portfolio effectiveness studies, which is really kind of the situation of there's really strong momentum or inertia in a system and they're rolling it out and we have to start doing evaluation. They're going to deliver this intervention regardless. Let's actually test it. Let's actually study the implementation at the same time. So similar for any implementation trial, one of the considerations for a hybrid type 3 is how much power do you have? If you're going to plan to do this, know that you're powering on a outcome that potentially is site level, deliverer level, or something that's not patient. So you're like, oh, I got 20,000 patients in my study. Right, but if you're rounding up your reach rate to a clinic level reach rate and you have 36 clinics over X amount of time, you then have an N of like 485 data points, let's say. You don't actually have 20,000 data points. So it's really kind of challenging to think through this, and you want to get, don't start writing a grant like this 6 weeks before the deadline, because the power and all the stuff that goes into that is really, really kind of challenging. So some other things in hybrid type 3s, you're going to want to actually talk about the evidence for the implementation strategy selected. This is another one of the tricky things for type 3s is that there's an expectation that your intervention is highly effective and has evidence base, and that your implementation strategies do too. If they don't, you probably are actually looking more at type 2, because that's where you're actually generating the evidence that the strategy is effective at the same time. I mentioned a little about the mechanisms of action of the strategies that may or may not be of interest to you, may or may not be of interest to your funder. Just pay attention to that in any FOA that you respond to. And we did talk a little bit about costs. So clinical outcome data collection, we've talked a little bit about, do you really need it? There may be some interventions that you do not need to do a hybrid study for. You could just jump directly to implementation. But again, I've heard more or less explicitly from multiple POs at NIH, like, I don't see a situation where we're going to be interested in a pure implementation study if you're not also going to give us some data around effectiveness. So these may be pretty rare, at least in kind of the NIH funding world. Are there measures available in existing data? Are there things that you can leverage? We often are using data that's already routinely collected by the system as our effectiveness data. Again, it's not going to be gold standard. It's not going to be perfect. You're going to have missing data. It may not be the best measure ever, but it's good enough. So look for ways that you can leverage existing data. That also helps reduce your cost of data collection. Okay, I'm going to just that. Okay. So Keep It Up 3.0 is a hybrid type 3 example. This was a internet-delivered HIV prevention program. The primary outcome paper is actually under review right now. We published our study protocol paper in Contemporary Clinical Trials. So the main thing here was that we actually did a fully powered test of 2 different implementation strategies. They were multi-component, sort of more like models or delivery like kind of big delivery strategies. One was delivery of the intervention through community-based organizations, and one was direct to consumers with no brick and mortar, no provider, just our team as sort of the technical assistance provider, and you can sign up to the app like you do anything. So here's what we had. We had a primary focus on comparing those 2 strategies. Our secondary focus was to ensure that Keep It Up was still effective on participants' HIV-related health outcomes. This was a situation where when we had our initial discussions with NIMH and NIAID, they said, you're going to have to beef up your health outcome because we want actual tests of HIV status. Okay. We were trying to get away with something much less burdensome on the participants and on us, but they said, no, we'll pay for it. And we said, okay, if you're going to pay for it, we'll do it. So that's what we did. The cluster randomized trial ended up actually being 66 counties that had the highest rates of young MSM with new HIV infections. We used CDC data, surveillance data to get that. And we had a 2-to-1 randomization strategy with double the number of sites or double the number of counties doing the CBO delivery versus the DTC strategy. And one thing that's actually kind of cool about this that I'm happy to talk about at some point is we did something fairly unique, which is we put an RFP out in year 1 for CBOs to actually submit grant proposals to us to be part of the study and get funding to deliver the intervention. So that's how we actually gauged interest and had a little bit more of a realistic approach to adoption, because this is how this program would get scaled out if CDC was to start supporting it. They would put an RFP out. So kind of a very real world approach to adoption. Okay, let's go back to hybrid type 2s. So again, this is that equal balance of effectiveness and implementation. We're looking at the performance of the intervention and strategy simultaneously. The strategy is explicitly hypothesized to be real world ready. This is not a highly burdensome strategy that we're using just for our effectiveness study, but we're using strategies that can actually be done by the systems. We are most commonly doing summative implementation outcomes like reach, adoption, and fidelity, rather than type 1s, which again are mostly looking at process data, may not even be getting to some of these more summative outcomes, just depending on the nature of the study. I had somebody one time be like, oh yeah, we were able to reach 420 people and we had a target of 400. I'm like, that's not reach at all. But that, in the context of an effectiveness study, it makes sense why someone would think that. It's like, yeah, we got more people than we were targeting. It's like, okay, but that's not really reach, because there's many more people who are, eligible, who could have been offered, and we have no idea how many would have really taken it up. So this is going to be our first actual test of being able to do that. So Jeff does sort of a differentiation of what he calls a pilot version for implementation strategies. This is often when you don't have tons of evidence that your implementation strategy is going to be effective, or you're in a situation where you still need to do a individual level randomized controlled trial, but you still want to test an implementation strategy. What happens here is that in that one-arm study, you often have one strategy that you can test. Okay, the control or delivery as usual, not really a test of a strategy. So you can get a lot of information from that pilot and that one arm of the strategies that are being used for delivery. The less common, much more complicated, and much more expensive version is the dual randomized design, which is where you test and compare interventions and implementation strategies, and you randomly assign to both of those conditions. So what this tends to look like is that you'll have cluster level randomization of the implementation strategy. So let's say you have 20 clinics, they get one strategy, 20 clinics, they get another. And then within those sites, as people come in, they get individually randomized to 2 different evidence-based interventions, okay? Often one of those interventions can be standard of care, okay? So it's not like it's not like a comparative effectiveness where it has to be 2 bona fide interventions, but still, you can see the logistics and challenges of doing this. That's why there's very few of them. I kind of already hit most of these things. So one of the things that's really important for this is you have to have an implementation strategy that is plausible in the real world. I've seen this many times as a grant reviewer that someone says, we're going to do X, Y, and Z, just like we have done in our efficacy and effectiveness studies. And I'm like, facepalm immediately. I'm like, what you did in those 2 studies are not realistic. Like, you can't have supervisors doing fidelity assessments on every single one of your interactions with a patient. Like, that's just not how this is, like, not how real world works. So that can get you in a lot of trouble. You always have to have an explicit measurement of adoption, fidelity, reach, whatever those major outcomes are on the implementation side. These always happen. You have to at least 1 or 2 in a hybrid type 2. So what if your strategy leads to poor adoption and poor fidelity? Did you just compromise your test of intervention effectiveness? Yeah, probably. I mean, that's the long and short of it. But there's things to do to protect against this. So one of them is use strategies that have a relevant evidence base. If you have a concern that fidelity is going to be a challenge, make sure you're using implementation strategies targeted at fidelity specifically that have an evidence base. You can also build in adoption and fidelity benchmarks and have a little bit of an adaptive design where you then, if they have not hit benchmarks at a certain time point, you sort of up the dose essentially, or add additional strategies focused specifically on adoption, fidelity, whatever your benchmarks are. Build in measurement plans that help you address poor adoption and or fidelity as you go, so that you're not sitting there, after you've unblinded your trial, we're, in quarter 2 of year 5, and you're like, oh crap, man, we had really bad adoption. Oh, and we had really bad fidelity. It's like, now it's too late. Nothing you can do about it at that point. So really making sure that you have a bit of a sense of what's happening here so you can correct as you go, in a way that's not going to obviously bias or completely destroy the rigor of your trial. You have to build in time to deal with the possibility. Almost no one does this, but try to if you can. Anyone getting queasy? Yeah. Hybrid type 2s are hard. There's a reason that they're the least frequently done. They're both hard to pitch, they're hard to power for, they're hard to execute, they're hard to find enough sites for, on and on. I think we are getting better at them, so you're going to see more in literature in the future. But when we did the big review, I think it was 10 or 12% of all published hybrid studies were type 2s, which is not surprising. And about 50% or 60% were type 1s. Yeah, so Family Checkup for Health. This is a trial that I led with Katie Burkle at ASU. This was a non-randomized test of implementation conditions. So an integrated delivery in clinics versus a referral to external provider. The part that's really important about this type of a study design, even though these were non-random, these are still ways we can look at comparative effectiveness or comparative implementation. The actual test of the intervention, though, this is why it's a type 2, is that within each of these different arms, so if you were a clinic that was providing this, as a family who was eligible came in, they would get randomized either to service as usual or to Family Checkup for Health. Same exact thing on the other side. So we had families getting service as usual here, or they got the exact same intervention, okay? These have to be exactly the same in a comparative implementation if I'm testing against these 2, because if it's not, I'm confounding intervention with implementation strategy. And then you're getting into a dual randomized situation and a whole different kind of study design. But either way, this is how we actually did it. So 2 different implementation conditions, same intervention compared to service as usual. Sometimes that does not work to move forward. Okay, so this was just a breakdown of kind of the different specific implementation strategies in the 2 different conditions. Again, this is really kind of for you to be able to look at and compare. The blue box on top are the strategies that were shared across both arms because they were necessary for the execution of the project and everything. But then you can see exactly how they differed. And if we had differential implementation outcome effects, it was likely due to these differences in the strategies that we used. This is just a summary. You can see we stopped actually doing our review in the middle of 2022. But this is just showing a trend in the number of published hybrid studies in the literature. Right after the publication of 2012 paper, there was a bit of a slow uptake, and then around 2018, it really shot up. And there are lots and lots of hybrids in the literature now. So the update. This is our 10-year reflection that was, again, published in December 2022. Okay, so one of the biggest things is, are they really designs? So they had been called hybrid trials. When it was recognized that trial was too narrow and not applicable to a sufficient number of things in implementation research, they started calling them designs. It depends a little bit on your definition, but essentially in a paper that we wrote about study designs in implementation research, we defined research design as your procedures to select subjects, assign subjects to or observe them in different conditions, and assess before, during, and after assignment in the conduct of the study. There is nothing about hybrids that is reflective of that, okay? So what we proposed in this paper is that they are not really designs. They're also not limited to trials. If you are doing a trial, I think it's still okay to say you're doing a hybrid effectiveness implementation trial using a type 2, whatever. What I typically prefer now, though, is actually, I think it's on a later slide, but actually saying I'm going to do a hybrid type 2 effectiveness implementation study using a parallel cluster randomized trial design. Okay, it tells the reviewer or the reader, here's what my focus is going to be. It's equal on implementation and effectiveness. To test that, I'm going to use this type of a design. But if I just said I'm going to do a hybrid type 2 effectiveness implementation design, you don't really know what the heck I'm doing. Okay, so that was one of the big problems. Similarly with trials, not all research designs that we use are trials, and that doesn't mean they're any less relevant. Ooh. Okay, back to clippers 2. Okay, so the other question that we got a lot was which type of hybrid should you use? So there are indications in the 2012 paper that says if this is the nature of the evidence for your intervention, the nature of evidence for your strategy, here's kind of the path that you go. We further refined some questions that we'd been piloting in consults and workshops and published it with this paper. So the first question is, what is the nature of your effectiveness data? If you remember, that's the first question too on the subway, right? What do you know about the intervention? Okay, if there's any question about whether or not it's effective, you're probably not a type 2. It could be, but you're more likely a type 1 and you're definitely not a type 3. Okay. So this just helps you kind of figure out exactly which one you should go to, depending on what case you think you can make to reviewers in a proposal. Question number 2 is, how much do you expect the intervention would need to be adapted for where you want to study and use it? If it's only a little, now I would call these kind of like surface adaptations or minimalist adaptations, you can consider doing a type 2 or type 3, and consider including your adaptation process as a step or as an aim explicitly. In the example that I showed you before, it was aim 1. We want to adapt first, then move forward. If you need to do a lot of adaptation, you may need to do a type 1. It may be so much that you actually need to establish again that this highly adapted version of the intervention is still effective. This happens when you're trying to like change the age group that you're going with. Potentially you're moving this from an LMIC to the US or vice versa. So there are times when it feels like just too much has changed from the prior evidence that we need to actually make sure the evidence still holds. Okay. Question number 3 is, how much do you already know about implementation determinants? Okay, so if you know what are the primary barriers for this intervention in a particular setting, you can potentially move beyond a type 1. If you don't know much, you're probably in type 1 territory, or I may suggest actually doing pilot work to figure it out, then moving into the proposal. Whether it's still a type 1 or type 2 depends on the nature of your pilot results. But again, this whole issue of like, I'm going to understand barriers first, then figure out a plan, that's getting increasingly hard to get past reviewers because they're like, I don't really know what you're going to do. Like if you don't know your context and you're going to say you're going to change something and then test it, I can't really evaluate your trial design if I don't know what you're really testing. Okay. 4th question, how ready are you to evaluate a real world implementation strategy or package of strategies? So again, this goes into the feasibility, implementability, sustainability, whatever, all those different abilities that are associated with the strategy itself. Okay, are the things that we are using to support delivery actually things that can be done? Do we know they can be done, and do we know they can be effective in more typical real-world service delivery systems? And again, the more evidence you have that that's the case, the further you can move type 2s and type 3s. Okay, here's the section of the paper that I wrote, which is which research design should you use for which hybrid type? Okay, there is no rule about this. Like, I've heard people actually say, oh, if you're going to do a hybrid type 2, you have to do dual randomized and you have to have, and it's like, no, that's not, like, it's not about that. That's the whole problem of having called it design, is that people started getting these thoughts. I've heard it from people who, it's unfortunately very problematic that they think this way because they make funding decisions. But regardless, so your research design should always depend on your research question. Okay, first and foremost, if your research design doesn't align with your research question, you're dead in the water no matter what hybrid type you say you're using, doesn't matter. So they're not intrinsically linked, but hybrid type 1s tend to favor intervention outcomes at the person level, okay? So a lot of them are gonna have individual level randomization, okay? Nothing wrong with that. Hybrid type 3s, because they favor implementation outcomes at a place or setting level, are likely to be clustered designs or having a place level focus, okay? That's just what it's gonna look like. I have seen several type 3s that were individual level randomized controlled trials. In those situations, the outcome was almost always fidelity because it's the only implementation outcome that is reliably evaluated at the individual level of delivery. Hybrid type 2 studies blend the two. So your relative emphasis on your implementation outcome versus your effectiveness outcome is going to drive your design choice. Again, individual level randomized trials can be done in type 2s, but it's typical to have clusters. You can also do observational designs, non-randomized designs, and many designs are used for formative and pilot work, pre-post designs, interrupted time series, all those things. You can use any of the hybrid types with those study designs. And again, it just goes back to the nature of your research question. There is actually a paper by Justin Knox and a couple other folks that talks about observational implementation hybrid studies. Interesting read, but it's basically situations when randomization and doing a more prospective trial is just not possible. And so they have some nice ways to think about if you're going to do an observational study, how do you make it a hybrid essentially? Okay, question 4, general challenges with the typology. So again, it was created with a mindset of clinical research. It doesn't work so well for health promotion, public health type interventions. I've encountered this personally. I often just don't call them a hybrid in this situation. I hate to say that, but you don't always have to do a hybrid. Even if you have an implementation question and an effectiveness question, it doesn't have to be a hybrid. Totally fine not to call it that. So the other question is too of whether it fits for policy research. And this is a really kind of like nuanced question about like, what is policy implementation research anyway? Jonathan Pirtle has a really nice paper about how to think about policy and implementation research. I think if the policy itself is the thing you're trying to implement, it lends itself fairly well to a potential hybrid typology. Also, if the policy is your implementation strategy, then it can also lead itself well. But it's kind of a tricky area and no one's really had a definitive paper on that. So again, what's happening now is really that the hybrid typology and saying I'm doing a 1, 2, or a 3, you all should now understand that this is shorthand for what my focus is, right? If I say I'm doing a type 1, you're like, oh, you're mostly focused on effectiveness. I'm doing a type 3, oh, you're mostly focused on implementation. It's really what it's turned into is the relative emphasis on the different questions. But there's also a recognition that it does not capture nuance. So we always have a little jokey thing about, well, there's no perfect type 2. There's also no perfect type 1 or type 3. What you actually have is every gradation in between. And so I've put in, never in a grant proposal because I'm not that cheeky, but in papers and presentations, I've actually said this is like a hybrid 1.5. This is a hybrid 1.75 to acknowledge that it's not a perfect type 2. Like I'm not perfectly able to answer both of these questions. I have trade-offs because of study design, availability of data, et cetera. And sometimes it's like a 2.3. It's like just remember it's on a scale. The typology is just shorthand. Not everyone agrees with what the thing is. So you'll see times when people are proposing a hybrid study that is testing the effectiveness of an implementation strategy, and they're calling it a type 1. Because this, in their mind, the strategy is the thing. Maybe, I don't know. That's just not how most people think about it. So be careful. It's a slightly unorthodox thing, or way to kind of pitch hybrid typology. We are still recommending using the typology, but we're using it with more nuanced language. So saying like, in the like overview of study design, you're saying, we are choosing to do a hybrid type 2 because, or something like that. You can say here instead, we're going to do a study that is largely consistent with a type 2 to acknowledge that it has some variation, that it's, 2.1, a 2.3, whatever it is. And I would argue that nuance is almost always at play. So just be as accurate as possible when you're using a typology. There's an entire section about how cost is analyzed in hybrids in the paper. You're probably all aware that there is an increasing attention being paid to implementation strategy costs. It's not always easy to do. Doing a really good costing approach is got a lot of data collection. It's often quite burdensome. Cost analysis and cost effectiveness can be done in any kind of hybrid type. Again, this is the whole issue of the hybrid types don't dictate what you can and can't do. You can incorporate this in any of them. One thing to remember is that if you're used to doing more of a conventional cost effectiveness analysis in an effectiveness type study, make sure that you're including implementation costs. I don't know how many that I've reviewed or seen in the literature that talk about just the delivery of the intervention as the cost. Nothing about all the stuff that had to go into the IT support, the training, fidelity monitoring, whatever else goes into actually making the intervention work. They just said like, oh, everyone gets 14 hours and we build this many hours, we build this much for 14 hours. Here's the average cost, and that's the intervention cost. It's like, okay, but that's not actually what it costs. Yes, so team sport for sure, seek professional help. I have learned a ton from working with health economists. I've also learned that not all health economists are interested in this type of health economic question, okay? This is kind of micro, niche, I don't know, but not every health economist wants to work on this level or scale, I guess. There are lots of examples being published. So I think if you want to propose cost effectiveness or just implementation costing in hybrids, there's lots of studies that has them out now. I'll do my little in summary just because why not? So again, going back to this relative emphasis or focus, hybrids really cut across the entirety of this spectrum. So I mentioned this is complete hyperbole. We hardly ever do pure implementation studies. We also hardly ever do pure effectiveness studies anymore, at least when people are more implementation research minded. And hybrid type 1s are just a way for us to help people understand, and for us a little bit too, to figure out exactly where we should be focusing. So just keep this as a handy mnemonic. But again, go back to the first questions of what is the nature of the effectiveness data? What is the nature of the implementation strategy data? And then you can start building a case for which hybrid type you're going to use. And I would say too that one of the things I've definitely appreciated in having reviewed a lot of grants in the last year and a half, make sure you tell reviewers why you are doing the type you are. Okay, make sure you include the rationale and justification that this fits this type of hybrid. I don't know how many that I read that people have said I'm doing a type 2 because I have both an implementation question and an effectiveness question. It's like, okay, that's the most basic understanding of this as you could possibly demonstrate. And that makes me immediately irritated as a reviewer. So make sure you're saying, I'm doing a type 1 because the effectiveness data for this intervention is X. In our prior studies, we have gathered implementability, feasibility, et cetera data for the implementation strategies that we are proposing. And here's our focus on X, Y, and Z outcomes. That's perfect, okay? Then you're like, oh, I get why you're doing a type 2. It's well reasoned. It's not just because you're interested in both. So that is my talk. I don't know how much time we have left because I am not paying attention to the clock at all. But yeah, let's have questions and discussion. Right on. Oh, cool. Okay. Let's talk hybrids. Porshka. We have that language. Yeah. Yeah. So It's definitely in the paper for sure that we recommend, like, here's how to say this. It ends up being a mouthful. That's the one thing I don't like about it. Because you do have to say hybrid type and you say the study design. If you're doing like a dual randomized or you're doing a embedded trial design, you may just want to say that using an embedded trial design, using a dual randomized design, because you don't want to say using an individual level randomized trial to test the effectiveness and then using a cluster randomized trial to test adoption at the clinic level. Like that, again, I just made it even worse as a mouthful. But yeah, always start with hybrid type study, followed by your actual research design. Tyler.
Briefly about how adjunctive intervention is.
Yeah,
Glossed over.
I did.
So I'd love to hear just what your thoughts are around adjunctive interventions, the third conceptualization
Yeah.
for us moving forward, because I really like the conceptualization. How does it fit into the hybrid design?
Sure. Just as a show of hands, who has heard of adjunctive interventions? Who has read the paper on adjunctive interventions? Who read the abstract of the paper? Okay. Totally fair. Totally fair. So just a very short introduction to adjunctive intervention. So everyone's probably aware of the difficulty of just, there are things we do to try to change behavior and implementation research that you're always kind of having this false dichotomy almost of like, is that the intervention? Is that the like health or clinical intervention? Or is it an implementation strategy? And what we argued in the adjunctive intervention paper is that there actually, in some cases, it's not every time that you can't figure it out cleanly that it's an adjunctive intervention, but there are a specific kind of change method that we call adjunctive interventions. Best example that I can give is we're doing a study of the implementation of pre-exposure prophylaxis, okay? Using, I don't know, let's say we're doing an integrative care delivery approach that involves strategies of training providers to assess and prescribe for PrEP, okay? So that's our implementation strategy. PrEP is our evidence-based intervention. But we also know that, at least when everyone was doing PrEP as a one-a-day pill, that adherence was a huge issue, okay? It works if you take it every day, therefore we need potentially to have adherence interventions, okay? The adherence interventions, we argued, are these adjunctive interventions, okay? They're not, in and of themselves, responsible for the clinical health outcome. You still have to take PrEP. Like I can give you an adjunctive intervention that helps you like be motivated to be adherent, but if you don't actually take the pill, you're not actually reducing your risk of new HIV infection, right? I feel very motivated, but I didn't actually do anything. That happens in hypertension as research as well. I do a lot of stuff in blood pressure control, and it's the same thing. Like I can be very motivated, but if I don't take the pill, my blood pressure does not actually change, okay? So these adjunctive interventions are also not a strategy because they're targeting the patient and they're often delivered by the health system itself. So they look kind of like an intervention, okay? The place it gets really difficult, I think this is why Tyler's asking the question, is when you start thinking about 3 different levels of change methods, you have your implementation strategy, you have this adjunctive intervention that's targeting patient outcome, and you have the actual intervention that's responsible for patient outcome. How do you like put all that together in a single project, okay? So what we argued is that the implementation outcomes of the adjunctive intervention are almost always engagement, adherence, motivation, these kind of precursors to hard implementation outcomes. And I mean like reach, fidelity, adoption, et cetera. Those adjunctive interventions help you sort of get to those places and supplement and help you explain potentially why your effectiveness data was the way that it was. But we also argued that you need implementation strategies for both the adjunctive intervention and for the health intervention. So there may be things that I'm doing to help with PrEP delivery itself that are not applicable at all to the, let's say it's a e-health based or a text message based adherence intervention, okay? That as an adjunctive intervention is a different pot, it's a different pile. To answer your question, I don't know. We have lots of hybrid studies that do have adjunctive interventions built into them. And I think honestly, what we tend to do is if the adjunctive intervention is very well established and it's not like the experimental thing, it's just kind of there. It's in there, it's in the project. We're potentially looking at whether it works by looking at those, the kind of engagement, participation, adherence data itself. I think what would happen if you had an adjunctive intervention that was totally new. So PrEP well established, we'll keep with that example. Lots of training for PCPs has been shown to be effective as an implementation strategy. Okay, those things that we don't necessarily need to study those. So those could sort of be the peripheral. Those are the things that are included, but you're studying multiple different adjunctive interventions, one delivered by a community health worker, one delivered by an e-health kind of tool or HIT. In that case, you would randomize to the adjunctive intervention that they get, and you would study or randomize people to the strategies for the adjunctive intervention. But you would just still use the well-established strategies for PrEP, and you'd use PrEP as those two things. So I think you would kind of almost like put a magnifying glass on the adjunctive piece. And I think you can still use the hybrid typology. You would just have to say that the thing that I'm testing here is not the health intervention, it's the adjunctive intervention, and we will still study the outcomes of the health intervention because that's still important, and we'll do something to study the interplay.
As a follow-up to that, if in that case, what's your reach? Reach is
Both.
PrEP prescriptions prescribed.
And how many people get and actually engage with the adjunctive intervention. So you have two levels of reach. If your primary focus is going to be on the adjunctive intervention, then that reach metric would be your primary reach metric. But then PrEP would still be, the reach metric for PrEP would still be very relevant. You still want to capture it.
I mean, if we're behavioral scientists and we do a lot of that adherence work,
Yeah.
Separating those two things, but I think
So there's an
sense to do that, but it just seems like
here's the reason that it came about. So in a lot of interventions, you have engagement or otherwise like adherence components built into the behavioral intervention itself. In that case, as long as that's working appropriately and you're viewing it as a package, there's really no need to like separate them. What you end up seeing is like in hypertension, for example, and I think in PrEP previously, there often was never an attempt to even talk about adherence. So I have hypertension. When my doctor diagnosed me and said, hey, you need to take, antihypertensive, I was like, sure. No discussion about, do you think you'll be able to take it every day? No discussion about the importance of taking it every day. And I am, of course, a very, good little patient. I do take it every day. That is not the case with everybody. So one of the other things we talked about that is in the paper, but it's maybe wasn't as emphasized, is that adjunctive interventions are also not always necessary. So they may be necessary for you getting antihypertensive for whatever reason in your context, your individual person, but not for me or vice versa. So we've said that it's necessary but not sufficient for some people. In other situations, it's just like it could be viewed almost as an adaptive intervention. So if someone is actually having low adherence, low compliance, you add on the adjunctive component to try to get them back to being adherent. So it's really when you're like adding a component to something else. Well, in that case, then we're getting into like study design, right? But
it also depends on what your effectiveness outcome is. If it's motivation, I grant your point. But if your effectiveness outcome is pills taken per day, average pills taken per day in the past week,
yeah,
then I don't think you're talking adjunctive anymore.
Potentially, but I think also too, if we're in the like world of hybrids, your effectiveness outcome is always an endpoint health outcome. Like motivation would never be like the effectiveness outcome. It could be the outcome of the adjunctive intervention, but it can't be the overall like effectiveness outcome because that has to be the health outcome. So a lot of this like thinking is based on causal paths and theories of change and theories of action. So it's really like what causes what and where in the path does this lead? So again, like most really good interventions will have components trying to help people address barriers to adherence, barriers to using the intervention, that kind of stuff. When they don't, you have an opportunity to potentially layer on an adjunctive intervention or potentially to change the type of adjunctive intervention that you give based on patient characteristics, system preference, that kind of stuff. So there's quite a lot of examples actually. Contingency management is a really good example that they actually used the term adjunctive before we coined it. They didn't say it was an adjunctive intervention. They said it's adjunctive to the thing that actually is going to create the change. So contingency management by itself doesn't do anything. If it helps you actually do the thing, then it has an effect. So it's sort of that kind of logic. Yeah, I feel like I'm a lawyer right now, like trying to get into some logic argument, which is not a good place to be. Okay. Yeah.
Getting closer. So say we have like, the premises, oral preface, subpopulation, etc. You're gonna need to think
Yep.
about that.
100%.
And so would an adjunctive intervention be like if we experience adherence issues with the patient and it's a long-acting infection? That'd be something different.
That's different. So that would actually be more of an adaptive intervention approach. What we're talking about here is really whether you can predict from the beginning that a person is going to need help being adherent to the intervention, or if you collect data around adherence that you can then use to make a decision to add on something else to help them. It doesn't involve treatment switching. That would actually be a little different, more of an adaptive intervention approach.
Even though you know they're gonna need.
Yeah, but you know they're gonna need help is like that a priori thing. So you may be able to say like, okay, let's say you had a prep clinic, and you know that everybody who injects drugs has these particular challenges. You could just say as a protocol, we're always going to add this adjunctive piece on with any patient who says that they're an injection drug user, because we know that this barrier exists. But I may not do that for a cisgender female who comes in who doesn't have a history of injection drug use, doesn't report the same kind of barriers to use. I may not have to use adjunctive intervention at all, which is kind of this like little distinction about why it's like even potentially necessary as a thing. But again, this is like a new area, so yeah.
I have two questions. One a silly one. In the SMART trial, when you were doing direct to consumer,
Yeah.
how did you define the denominator of reach?
Oh God, that is a fun one. Actually, in both of those studies with the direct-to-consumer model, it was really hard. Part of the reason that we couldn't get a denominator, so reach can just be the number. It can just be the number reached. So it doesn't have to always be expressed as a proportion. You're limited if you can't do that. What we ended up being able to do is basically anybody who visited the landing page to sign up for the study was considered in the denominator. Anybody who signed up and was determined to be eligible got into the numerator.
Very cool.
It's not great. It's not perfect because a lot of people who were not eligible landed on the page. So in a very strict definition of reach, those people probably should have been excluded. We did exclude if they were determined ineligible after they signed up. They were just excluded completely. But it's not perfect, and it was one of the biggest challenges, honestly, of that whole study.
The other question I have more substantial is in the type 1 primary effectiveness hybrid trials. When you start doing implementation A3 type stuff,
Yeah.
a lot of times it seems to me there's an assumption that examining the facilitators and barriers to your effectiveness intervention is the same thing as examining the facilitators and barriers to what's ultimately going to be your intervention in what might be a type 2 or a type 3 trial.
Yep.
In some of the grants that I review, that's not the case at all.
Yep.
You've got a type 1 intervention that's couched in paid participants, doctorate level interventionists in highly controlled university settings, not clinics, not regular community providers.
Yeah.
And there's this play acting.
Yes.
Pretending we're doing an implementation in 300.
Yeah, so you're introducing a third variable that I didn't want to talk about, and I'm going to, which is the whole pragmatic to explanatory trial continuum. So, pragmatic and who's familiar with the like PRECIS, PRECIS, pragmatic explanatory indicator continuum? No? Orshika? You're the only one. Okay, got it too. So essentially what this is it's 8, I can't remember if it's 8 or 9 different categories of research design choices that if they're more stringent, typically you're getting closer to the center of the circle. They'll be rated like a 1. versus a 5 that's highly pragmatic. So one example that we can all probably relate to is the inclusion-exclusion criteria. The more narrowly defined your inclusion criteria, the more of an explanatory trial you are. So if I'm saying I want these types of patients with no comorbidities, no like other things, they've never had a trial, like they've never like had a medication before, enough, all that kind of stuff, we are very restricting who can be eligible, and therefore the actual interpretation of who the intervention is effective for. As you start to go into effectiveness research, you typically expand your inclusion criteria, but you don't have to. My whole point here is that the design of the study, the effectiveness study, the more pragmatic it is, the more that AIM-3 study of various facilitators is potentially generalizable and relevant. If they are proposing a highly explanatory effectiveness study, I completely agree with you. Like what, I don't know, you're going to learn very little. There might be still something, but this is not how this study would ever be actually, or this type of intervention would ever actually be rolled out in the real world. So whatever you say from that AIM-3 is very limited. It comes with asterisks, caveats, all sorts of, language.
That's a
like
nice
that.
way to present it to review.
Yeah. Other questions?
Sorry.
No,
could
go ahead.
you just repeat that? Is that precise?
It's pronounced Precis, but yes, PRECIS-2 is the one that you want to look at. And there's also a -PS, which is the provider strategies one, which gets more into actual implementation research questions. And that was lead authored by Wynn Norton. Really helpful, actually, the Precis 2. I've used actually the Precis wheel in grant proposals to demonstrate in what ways we're pragmatic and what ways we're not. And it has always been commented on as a strength of proposals. It takes up a little bit of space. Question?
Trying to formulate the question, but it's really around the integration of adaptation,
Yeah.
efficacy, and implementation. And we write a lot of these grants where we have this lovely thing that seems to work in this, high income setting. We do a lot of work in sub-Saharan Africa, and we have to do a lot of adaptation work. So I'm reminding of your slide where you pointed to if you're doing more adaptation than not, it's probably type 1. But reviewers are very interested in driving it forward toward the implementation stage.
Yeah.
And there's this tension between, are we actually testing efficacy? I mean, because we're doing a lot of our work in clinic. So it's not, in the university setting, but it's still, you're testing efficacy because it's an adaptation. I struggle sometimes with that line of when can we actually call it a hybrid versus when is it still efficacy in that adaptation space, if that makes sense.
Yeah, it's really hard, honestly. Like anytime you start to do adaptation, and I've multiple minds about it. I've gone back and forth over the years about saying, yes, if you're going to do like a substantive adaptation, make it an AIM, use an adaptation model, like go through that process. If it's really going to be kind of minimal adaptation, that doesn't necessarily need that type, don't call it an AIM. Just put it in your like year 1 activities and don't draw a lot of attention to it. And honestly, like if you're proposing and you're open, like don't, bury the lead here and like, we're going to do major adaptation and just not talk about it. I'm not saying doing that, but if it really is the case that the stuff we're going to change is not changing the underlying potential like theory of action and the causal paths that are responsible for the intervention's effectiveness, you can potentially just say like, yeah, these are surface level adaptations. If you go back to the original consolidated framework for implementation research, Laura Damschroeder called this the adaptable periphery. And the point of calling it adaptable periphery is that we're just changing little things related to like, maybe like where it's delivered, who delivers it, but potentially those things don't have an impact. Some do. And sometimes people want you to test it, to show that they didn't have an impact. But I sometimes don't draw as much attention to the adaptation as
That could be the difference between those one.
For sure.
About how much implementation you're integrating.
Yeah.
They become entirely different studies.
They do. And I don't, Borska's probably thinking similarly, like, what if you're adapting during the implementation? Like that happens often. And we just, I don't know why we kind of ignore that, but sometimes we just don't we just let people do that. As long as it's, no, in an R1. Yeah, Borska, you were gonna say something? Yeah.
And so what are the differences
you identify what kind of form function that you want to change, and the forms change, even though many people will get anxious about that still.
Yeah.
But I think that for me, that has been kind of my savior for my own peace of mind, that saying that, the functions have not changed, we really changed the forms to better fit with the local setting, population, etc.
Yep.
And so I'm not going to go through another efficacy study
Yep.
to retest the same intervention just because I made those changes. But again, this is very squishy, and I agree with Judy, I have multiple ideas about it.
Is there a reference for that? You have a reference for that function and form?
Yes, yes. it's
Picori.
Perez, and I would have to share it with the organizers. That's a good, I think that's a kind of an alternative.
Yeah, and the Picori white paper about it as well is a good one to go to.
Yep, form functions and form of complex health interventions.
Yes.
Yeah.
And there are a number of publications that we have recently applying that.
So another little trick, which goes to this form and function thing. If you're going to make the form and function argument, which I do think is valid, if you don't incorporate this in the initial submission, be ready to do it in the revision, is you may need to get some sort of mechanistic outcome that shows that the thing you changed didn't change the function. Okay, because people will say things like, well, how do you know you're not changing the function if you change the form? Okay, so build in potentially a test of here's what's supposed to happen. Let's ensure that that happened if you're making an adaptation. So one example could be moving from independently licensed social worker to deliver something to community health worker. You're like, well, they're doing the same thing. But a reviewer might say, yeah, but you're moving from a very highly clinically skilled individual who probably brings a lot of other stuff to the table to a community health worker who may not be as highly clinically trained, but they bring different stuff to the table too, because they have different kind of skill set. So how do you know that just by the very nature of changing the service provider, you have not actually inadvertently changed the function of what they actually do? So you may just want to actually incorporate a test of at least one or two functions to show, hey, in this study, we changed the form, but the function did not get affected. So that doesn't always convince reviewers, but that is a little bit of a fail-safe, potentially. And I think it shows that you're thinking about it, you're acknowledging it. I think one thing that reviewers get a little irritated about with adaptation is that everyone wants to say, oh, this isn't going to have an effect. When honestly, we don't really know. Like, we don't. So building in some things to say, like, I'm aware that I'm changing this for implementability, I'm changing it for feasibility, for fit with context, and I'm going to make sure that that change hasn't affected the mechanism. And it could be very low cost to be able to build in that collection of that data to make a reviewer happy. Yeah. Didn't talk about that in the paper, but that, so I've always, so all of, yeah, well, not really, but everything that I said so far is really talking about like once you get the intervention. Okay, so once like I know you're eligible for PrEP, I'm going to give you the prescription. I'm anticipating you're going to potentially have challenges taking it every day. Now I'm going to like do some additional stuff to help you proactively overcome barriers using adjunctive intervention. The other place that we talked about using adjunctive interventions was with initial adoption or uptake. Okay, so if someone comes in and they're like, oh, you're eligible for PrEP, would you like to consider it? And they're like, I don't know, I've heard like, X, Y, and Z thing about it. I don't really know for sure. At that point, a provider could be like, oh, okay, fine, done. Or they could potentially introduce like motivational interview, right? It's like, okay, let's actually talk about what your reservations are, what would be the pros and cons of doing this. That in and of itself, that is an adjunctive intervention. So you are not trying to increase, and you're not trying to increase adherence at that point. You're trying to get someone's initial uptake, just to have them say yes. In that particular situation, you could pretty easily actually just ask someone a 1-question or 2-question survey at their intake. Let's say if you're a PrEP clinic, everyone's coming there to see if they're eligible. potentially say like, how interested are you in this? Like, what's your level of motivation, or whatever you want to couch that. And that could be your entree into saying, okay, I'm going to be prepared to be able to deliver motivational interviewing to you as we discuss taking a prep prescription. Similarly, you could probably also say like, if you're taking a 1-a-day pill, what are some challenges you anticipate? And if they indicate more than one thing, then you could probably say they're indicated for the adjunctive intervention.
Not to like drive this way like home. I know you're like, we don't want to talk about adjunct.
No, I don't want to talk about it.
I'm curious now. So let's say, for example, I decide to use psychoeducation. People do not want to like go into therapy because they're not quite sure like what the deal is, right?
Yeah.
And let's just say in the grant application, I did not talk about even the option for
Having that.
adjunctive. Yeah.
Yeah.
How would I like account for like, could I just kind of like, how would I account for that?
Well, if it's something you realize you need after your study already gets going, it's a different question, rather than something that gets built in. So if it isn't something that's built in, you're potentially going to, alter your study design in ways that are going to increase or not increase, but introduce potential sources of bias. So it's best to try to get ahead of this before and either have a adaptive intervention that basically tracks people's adherence. When they fall below a certain level, you automatically give them the adjunctive, or to actually just have it be a test of adjunctive intervention from the beginning and everyone gets it. Like, build it in some way. And where you run into problems is anytime you're trying to introduce something to address a problem that you didn't anticipate. Because then you're introducing something in the middle of a study design that then has implications for everybody else in the study and your overall rigor.
No, this is helpful.
Time?
Thumbs up.
All right. Thanks, everybody.
Thank you, thank you. Okay, so we have another 15-minute break and we'll be back by 3 o'clock. Yep. Thank you, everybody.